Let's see an NCLEX RN video based on care for patients with diabetes mellitus. The nurse documents glucose in the urine as which finding? Polyuria, glucoseuria, hyperglycemia, hyperosmolarity. Glucoseuria is glucose in urine. Polyuria is excessive urine output. Hyperglycemia is high serum glucose and hyperosmolarity is increased body fluid osmolality or concentration. What is measured by HbA1c, hemoglobin A1c test? Amount of glucagon stored in the liver, specific insulin levels in the blood plasma, levels of hemoglobin after physical activity, average blood glucose concentration over time. HbA1c is the average blood glucose concentration over time, and it is measured by the amount of glucose that binds to the red blood cells. Which are considered clinical manifestations of type 2 diabetes? Decreased appetite, poor wound healing, fatigue, hyperactivity, visual disturbance. So here the clinical manifestations of type 2 diabetes mellitus are poor wound healing, which is due to decreased peripheral circulation, fatigue, which is due to the breakdown of the fats and proteins for energy needs, and visual disturbance due to microvascular effects of diabetes mellitus. Decreased appetite and hyperactivity are not associated with type 2 diabetes mellitus. What is the most likely cause of the Somogyi effect? Basal insulin injections before bed without a small snack, naturally occurring release of hormones during the night, increased consumption of complex carbohydrates throughout the day, glucagon administration before breakfast. So Somogyi effect is the basal insulin injection before bed without a small snack. That time an effect which is coming is known as the Somogyi effect. The increased blood glucose levels of the down phenomena, you know that, result from the naturally occurring release of the hormones such as glucagon, cortisol and growth hormone in the early morning. Because the body does not have sufficient insulin to control this glucose surge, blood glucose level rises. This is most likely reflected in higher fasting blood glucose levels in the morning. The Somogyi effect results in increased blood glucose levels due to an excessive insulin dosage at night. This can occur in patient who injects basal insulin before bed without having a small bedtime snack. In that circumstance, the blood glucose levels drop and the body responds in the same way as in the dawn phenomenon, that is releasing the growth hormone, cortisol and catecholamine in an effort to increase the blood glucose by releasing glucose stores from the liver. In a diabetic patient, numbness, tingling and pain in the hands and feet are all symptoms of which complication? Autonomic neuropathy, hyperosmolar hyperglycemic syndrome, diabetic peripheral neuropathy, diabetic ketoacidosis. In diabetic patient, numbness, tingling and pain in the hands and feet are symptoms of diabetic peripheral neuropathy. It results when the nerves to the feet and hands are damaged. Autonomic neuropathy results when there are damage to the nerves of the autonomic nervous system. In diabetic ketoacidosis, the initial patient presentation is one of polyuria, polydipsia and polyphagia. The patient becomes dehydrated and electrolyte imbalance such as hyperkalemia or hypokalemia may result. The increased serum osmolarity also result in a shift of fluid from the intracellular to the extracellular space, causing a dilutional hyponatremia. The patient is also at risk of hypovolemia secondary to the osmotic diuresis. Hyperosmolar hyperglycemic syndrome is characterized by hyperglycemia, hyperosmolarity and dehydration without significant ketoacidosis. The nurse understands that type 1 diabetes mellitus is caused by which of the following conditions? Gestational diabetes, a history of mumps or rubella, family history of autoimmune disorders, autoimmune destruction of the beta cells of pancreas, obesity. Type 1 diabetes mellitus is caused by an autoimmune process in which the insulin producing beta cells of the pancreas are destroyed, and also the triggers are not fully understood, but a history of mumps and rubella are also sometimes implicated in type 1 diabetes mellitus. The nurse monitors for which clinical manifestation in patient newly diagnosed with type 1 diabetes mellitus? Polyuria, fatigue, weight loss, polyphagia, decreased appetite. Polyuria, fatigue, weight loss and polyphagia are all clinical manifestations of type 1 diabetes. Glucose is typically totally reabsorbed in the renal tubules. Hyperglycemia results in glucose excretion in the urine, which creates an osmotic effect that effectively reduces the water reabsorption in the renal tubules, leading to excess volume loss through the kidneys. That is how polyuria happens. Hyperglycemia also causes hyperosmolarity in the blood, which causes a shift of fluid from the intracellular space to the vascular space. The loss of intracellular water combined with the volume loss through the kidneys create excessive thirst in the patient or polydipsia also. The lack of insulin necessary to move glucose into the cells lead to the breakdown of proteins and fat as source of energy. This starvation of cells leads to polyphagia or increased appetite. Despite an increased appetite leading to consumption of large amount of food, the continual breakdown of fats and proteins lead to weight loss and fatigue. The nurse correlates which laboratory value with the diagnosis of diabetes mellitus? Fasting blood glucose greater than 140 mg per dl, HbA1c 5.8%, random blood glucose 150 mg per dl, oral glucose tolerance test 155 mg per dl. For this question, you need to know about the laboratory values of the diabetes mellitus. Here in this question, fasting blood glucose greater than 140 mg per dl shows the patient is having diabetes mellitus. Then the next slide, let's see what are the laboratory values and the interpretations. The fasting blood glucose, if it is more than or equal to 126 mg per dl, that indicates diabetes. If the value is between 100 to 125 mg per dl, that is fasting blood glucose, that indicate pre-diabetes. 2 hours postprandial, that is after meals, or the oral glucose tolerance test if you are doing, and if we are getting a value more than or equal to 200 mg per dl, that indicates diabetes. The value between 140 to 199 mg per dl indicates pre-diabetes. HbA1c more than or equal to 6.5% indicate diabetes mellitus, 5.7 to 6.4% indicates pre-diabetes. The random blood glucose level more than or equal to 200 mg per dl, that indicates diabetes mellitus if accompanied by classic signs of hyperglycemia. The charge nurse is reviewing orders for a newly admitted patient with type 1 diabetes mellitus. it is a priority for the charge nurse to follow up with the provider about which order. Novolog insulin subcutaneous at bedtime. Novolog insulin subcutaneous 15 minutes prior to meals. Basal insulin subcutaneous at bedtime. Correctional and nutritional insulin administration immediately after meal. You need to know, Novolog is a fast-acting insulin reserved for correctional or prandial insulin. Insulin administration at bedtime without adequate nutritional intake may result in hypoglycemia. So here, Novolog insulin subcutaneous at bedtime should be questioned. The nurse correlates which laboratory values as a diagnostic for diabetic ketoacidosis. Serum bicarbonate of 18 milliequivalents per liter, negative anion gap, serum glucose of 350 mg per dl, positive anion gap, arterial pH of 7.36. In diabetic ketoacidosis, there is inadequate insulin for cells to obtain adequate glucose for normal metabolism. The body attempts to obtain energy by the rapid breakdown of the fat stores, releasing fatty acids from the adipose tissue. The liver converts the fatty acids into ketone bodies, which can serve as an energy source in the absence of glucose. The ketone bodies, however, have a low pH, resulting in metabolic acidosis, a low serum bicarbonate, and a positive anion gap. The absence of insulin also results in an increased release of hormones such as glucagon and cortisol in response to inadequate glucose transport into the cells. This leads to gluconeogenesis and glycogenolysis, resulting in severe hyperglycemia. So here the diagnostic for DKA are serum bicarbonate of 18 milliequivalents per liter, that is low, and the serum glucose of 350 mg per dl, a positive anion gap. The nurse should intervene immediately if the patient has wished blood glucose level 200 mg per dl, 152 mg per dl, 80 mg per dl, 40 mg per dl. As the brain can only use glucose of its metabolic functions, a glucose of 40 requires immediate treatment to avoid potential irreversible central nervous system dysfunction. The nurse recognizes that blood glucose monitoring before meals and at bedtime is done to achieve which outcome? Maintain glycemic control, prevent complications of long-term hyperglycemia, facilitate insulin administration that mimics the healthy pancreas, provide frequent practice with the finger stick technique, prevent acute complications of type 1 diabetes. Blood glucose monitoring before meals and at bedtime facilitates insulin administration that mimics the healthy pancreas, which helps maintain the glycemic control and prevents complications of long-term hyperglycemia. The goal is not frequent practice. Acute complications can occur independent of glucose monitoring, such as infection or stress, which increase the glucose needs. So here the nurse need to maintain glycemic control and prevent complications of long-term hyperglycemia, facilitate insulin administration that mimics the healthy pancreas. The nurse is screening patients for the risk of developing type 2 diabetes mellitus. The nurse should consider which patient at risk: women with history of gestational diabetes, women with a history of multiple birth, men with a history of pancreatic cancer, men who are overweight or obese, men and women with cardiovascular disease. Multiple births or a history of pancreatic cancer do not increase the risk of type 2 diabetes mellitus. Pancreatic cancer may result in surgically induced type 1 diabetes mellitus. So here, women with a history of gestational diabetes, men who are overweight or obese, men and women with cardiovascular disease are at risk of developing type 2 diabetes mellitus. The nurse recognizes which of the following statements is correct in relation to the pathophysiology of type 2 diabetes. It is due to a relative lack of insulin. It is due to insulin resistance. It is due to an absolute lack of insulin. It remains stable over time. It is due to an autoimmune process that destroys the beta cells of the pancreas. Type 2 diabetes is a relative lack of insulin or due to insulin resistance. Type 1 is an absolute lack of insulin due to an autoimmune process that destroys the beta cells of the pancreas. Neither are stable over time. The nurse is reviewing orders for patients newly diagnosed with type 2 diabetes mellitus. What initial medication orders should be anticipated? Metformin per oral twice a day, nutritional insulin subcutaneously prior to meals, basal insulin subcutaneously before bed, correctional insulin subcutaneously after meals. Metformin is a drug used to maintain blood glucose level in type 2 diabetes mellitus. Insulin may be used later if glucose control cannot be maintained over time. So the other three options, if you see B, C and D, these are orders for patients with type 1 diabetes mellitus. The nurse is providing care for a patient newly diagnosed with type 1 diabetes. Which lifestyle modification need to be included in the plan of care? Limit exercise, carbohydrate counting, self-monitoring of blood glucose, distribute carbohydrate intake throughout the day, control weight, limit alcohol, carbohydrate counting, self-monitoring of blood glucose, healthcare provider visits as needed, limit protein intake, distribute carbohydrate intake throughout the day, regular healthcare provider visit. Recommendations for the control of type 2 diabetes mellitus include aerobic training and resistance training, controlling the weight which is associated with insulin resistance, distributing carbohydrates throughout the day in small meals and snacks, self-blood glucose monitoring, limiting alcohol as it contains carbohydrates, and regular healthcare provider visit. So here, distribute carbohydrate intake throughout the day, control the weight and limit alcohol. The nurse prioritizes which nursing diagnosis in the plan for care of a patient with type 2 diabetes mellitus. Risk for infection, risk for falls, risk for impaired gas exchange, risk for injury or hyperkalemia. Infection is a great risk due to poor peripheral perfusion and diabetic peripheral neuropathy, which decreases sensation that may lead to undetected injury and infection. Mrs. Simpson is a 63-year-old admitted for unstable angina. She is now 4 days post-operative following a triple cardiac bypass. She has a 15-year history of type 2 diabetes and is managed at home on metformin and glyburide. Her past medical history also includes the hypertension, hyperlipidemia, and a past surgical history of cholecystectomy. She smoked 1 packet per day into 25 years but quit 2 years ago. Her labs indicate an elevated creatinine of 2.2 mg per dl, glomerular filtration rate 27 ml per minute, 1.72 meter square, WBC count elevated at 12.5 into 10 raised to 3 millimeter cube, and a blood glucose of 220 mg per dl. Her laboratory values are indicating the presence of infection and the beginning of renal insufficiency. Her vital signs are within normal limits except for elevated temperature of 100.5 degree Fahrenheit. Blood and urine culture are sent to the laboratory and she is started on broad-spectrum antibiotics. Her blood glucose level is increased because of infection requiring increased insulin coverage. Intravenous fluids are maintained to preserve urine output. Her renal function is closely followed with daily laboratory assessments. Simpson is now 6 days post-operative following her triple cardiac bypass. Her cultures reveal a UTI and she is started on Bactrim. Her vital signs are stable, her temperature is within normal limit and her WBC count is back to normal. During her hospital stay, her diabetes is being treated with subcutaneous insulin. She is given nutritional corrections as necessary and basal insulins. Her blood glucose is back within tight glycemic control after an initial increase with the infection. Her urine output is stable and renal function test appears to be normal. The plan is to discharge her home tomorrow. So this is the case. The nurse includes which information in the teaching plan for Ms. Simpson? Daily insulin administration, once a day blood glucose monitoring, eliminating fat in her diet, monitoring for infection. Infection may impact Mrs. Simpson's glucose level. She should not go home on insulin and should monitor her glucose levels more than once per day. There is no need to eliminate all fat in the diet. Which statement by Ms. Simpson about her home medication regimen indicates the need for further teaching? My kidney problem will not affect my metformin prescription. I may not need to change for my metformin glyburide drug therapy because of the problem with my kidneys. I will need to be especially careful about low blood glucose. I need to be diligent with my self-blood glucose monitoring. Renal disease may lead to lactic acidosis if taking metformin, so it should be monitored. Which statement by Ms. Simpson indicates that teaching has been effective? I don't have to worry about my BP now that I have had heart surgery. My diabetes is separate from my heart problems. My blood glucose may go up if I get another infection. I can take 2 of my glucose pills to make up for a missed dose as long as I check with my blood glucose. Infection or stress may lead to increase in blood glucose. Heart surgery does not cure hypertension. Diabetes mellitus is associated with heart disease. Patients should not take 2 pills together to make up for the miss. The nurse recognizes that management of diabetes is more successful with which action? A priority focus on medication, a focus on regular healthcare provider follow-up, patient commitment to self-management, a priority focus on appropriate diet. Here, all answers are essential for diabetes mellitus management, but the patient's commitment for self-management is necessary to maintain the necessary measures for optimum diabetes mellitus management. The nurse understands hyperosmolar hyperglycemic state differ from diabetic ketoacidosis in which of the following ways? Hyperosmolar hyperglycemic state has a more gradual onset. Diabetic ketoacidosis presents with higher serum glucose. Potassium depletion is a potential complication with HHS. A positive anion gap is not diagnostic for HHS. Ketosis is typically not present in HHS. Diabetic ketoacidosis does not present with a higher glucose. Potassium depletion, a positive anion gap and ketosis is associated with diabetic ketoacidosis. So here HHS has a more gradual onset. A positive anion gap is not diagnosis for HHS. Ketosis is typically not present in HHS, but it is present in DKA. Hope you understood this video. Thank you so much.